We are moving to the sixth edition of 10 most impactful landmark publications in gastroenterology. Where you are now will be known from where you have come from. That is a very important thing, because if you want to know where actually what kind of practice you are doing, how it has evolved, unless you know it, how it has evolved. And many times my youngsters and postgraduate, they would like to know that what are the landmark, the changes happened, which has taken a different path and taken a really kind of the orientation for the today's practice. So this is the genesis of 10 most impactful landmark publications in gastroenterology. We welcome all our eminent faculty and delegates all over the world for this landmark publication in gastroenterology. Welcome to the webinar series. This has been organized by MedIndia Hospitals and Academy, Chennai, Tamil Nadu, India, which is affiliated to the Tamil Nadu Dr. MGR Medical University. I am very glad to inform you that all these webinar series have been accredited by MedIndia Academy with credit hours. I am further glad to inform you that, considering the uniqueness of this kind of landmark publication webinar and the eminent faculty we have got from both from India, abroad, these webinars, international webinars, have been endorsed by American College of Gastroenterology and American Society for Gastrointestinal Endoscopy. Earlier webinars, we have seen delegates attending from Nepal, Malaysia, Bangladesh, Singapore, Sri Lanka, Gulf countries, and USA. Our first webinar attracted more than 3,000 delegates. For that, we have made a very special virtual exhibition hall. If you just see this exhibition hall here, we have a lounge for ACG, and we have a lounge for ASGE, where you can click and see the resource material, and ACG also you can see the resource material, and you can register in the information desk, and you can get the material, whatever you want to know about academic sponsors here. And if you click it here about our webinar series video also, at the end of the webinar, you click here, you can download your own certificate, write your name, get printed. And you want to enter into the conference hall to listen to the webinar lecture, you have to press this button here. This is the virtual exhibition hall. I enjoyed operating this. Hope you will equally enjoy this. The first series, the first edition was held on 11th July 2020. We had stalwarts like Professor Sareen, Professor Reddy, and Professor Vineet Aguja talking on broadly on luminal disorders, endoscopy procedures, and hepatology. Later on, we realized it after seeing the stupendous success of and the people who really attended, they were appreciative of this kind of efforts. This is the first of its kind landmark publications in gastroenterology, which would benefit the postgraduate and everyone who cares for gastroenterology. The second edition was a little more focused, with Professor Goenka talking on small bowel imaging, and Govind Makaria talking on small bowel diseases, and moderated by eminent national faculty Ajay Kumar, Vijay Mohan Prasad, and SP Singh. The third series was held on 25th September. Monthly once we have been conducting this kind of webinar, and this is purely on pancreatitis and pancreatic endotherapy. The speakers were Professor Pramod Garg and Amit Medho, moderated by other eminent faculty like Ramesh Rupai and Matthew Philippe, and moderated, commented by the Professor V. Jayanti. The fourth edition was held on 23rd October. This is on hepatology and having hepatitis C inventors recognized by Nobel laureates. We wanted to honor the topic hepatitis C, spoken by Professor Anil Arora and NASH by Akash Shukla and moderated by Dr. LVK and Waldos and SP Singh. The fifth webinar became an international webinar, and the first four were we had predominantly eminent national faculty. The fifth webinar was an advanced endoscopy imaging. My friend Professor Noriado came from Osaka University, Japan, and another friend of mine, Professor John Salzman, who talked on non-variceal UGA bleed. He's from Brigham and Women's Hospital, Harvard Medical School. And the panelists were Professor Nalini Gouda, Vivek Saraswat from India, and Vivek Kaul from New York. Now, today, we are in the process of initiating the sixth edition of this webinar series on landmark publications. This is again truly international, sixth edition being held today. I have been the Professor Manuel Galva-Neto will be introduced by Mohit Bhandari and Dr. Rakesh from AIG. And the second topic will be by Professor Pratik Sharma, the topic being very important GRD and Barrett's esophagus. He will be introduced and the topic will be, and the whole session will be moderated by another good friend of mine, Professor Dr. Prasadji Iyer from Mayo Clinic. I have very great pleasure to introduce all of them. Those who could not make it, they can watch all these webinars right from the first edition till today and our future upcoming webinars also in YouTube, so they can hook into the YouTube and watch these webinars. Our forthcoming series, the 7th edition, will be on Saturday, 23rd January 2021. And this is on biliary diseases, stone and stricture, and will be spoken by Professor Todd Barron from North Carolina, USA, and endotherapy by myself. And will be having the topmost panelists, Professor Richard Kojar, Murthy Badiga from USA, Professor K.R. Palanisamy from India, and Professor Randir Sood from India. The same day, we have been honored to have the Professor Dr. David Greenwald, who is the president of American College of Gastroenterology. He will be delivering the MedIndia Oration on the topic shifting paradigm in GI care. And as per the convention, that he will be awarded a plaque and a medallion with the MedIndia Oration Award in recognition of his outstanding and pioneering contributions to the field of gastroenterology. The 8th edition will be the last one in this series. It will be on Saturday, 28th February 2021. And two important topics, third space endoscopy, will be delivered by Professor Noria Fukami from Mayo Clinic, Arizona, USA. And another very important topic, an interventional US by another very eminent international faculty, Professor Dr. Kenneth Binmoller from California Pacific Medical Center, USA. And we have panelists from all over the world, Professor Mustafa Ibrahim from Cairo, Egypt, Professor Amitabh Chak from Ohio, and Amul Bapai, our own Indian faculty, and Sandeep Laktakia from AIG Hyderabad. And the same day, Professor Douglas Rex will be delivering another MedIndia Oration Award 2020. The topic will be colonoscopy today and tomorrow. And again, we are honored to have the President-elect American Society for GI Endoscopy USA, Professor Rex from Indiana University School of Medicine, Indianapolis, USA. The important thing, the proceedings of the 8 webinar series will be published as a book as required and as decided by many of our colleagues and the delegates. And those who attend, the Indian doctors will get the CME credit hours from the Tamil Nadu Medical Council. And as I mentioned you in the virtual exhibition hall, you just go to you click over the certificate, and you get the virtual, I mean the e-certificate, print your name printed on the certificate with the date also mentioned, and the e-certificate of participation will be emailed to the registered delegates. Okay, and this has been possible with the continuing efforts and the support rendered by my colleague Dr. Satyamurthy, Dr. Raja Yogesh, Dr. Gokul, Dr. Prasad, and Dr. TNS, who is an intensivist. This no program would have been possible, is possible without the aid from the academy partner. I am very grateful to Microknowledge Academy for sponsoring all these webinars. Thank you very much for listening to this introduction. I bring warm greetings from MedIndia Hospital, Chennai. And those who want to listen to the talk either after that also webinar also, they can hook it into the YouTube and the Facebook also. And now I have a pleasant task to introduce 3 of the panelists before we start the first topic. Yes. Doctor, am I audible there? Hi.
Yeah, you're audible, sir. You're audible.
Okay. I have a pleasant task to introduce an eminent faculty. Is it the slide is seen there?
Yeah, we can see.
Okay. Dr. Prasad G. Iyer is an eminent gastroenterologist. He is a consultant gastroenterologist, Division of Gastroenterology and Hepatology, Department of Internal Medicine. I think every doctor's dream is to join Mayo Clinic. And he has done it. And he has done a great job because of sheer hard work and clinical applications and publications. He is the consultant in Mayo Clinic, Rochester, USA. His academic rank is Professor of Medicine. He is the chair, International Committee, American Society for GI Endoscopy from 2013 to 16. He has been the associate editor of Diseases of the Esophagus and chair Esophageal Section Annual Scientific Program Committee, ASGE. He has received a Governor's Award for Excellence in Clinical Research from ACG. He's got a special interest in Barrett's esophagus, esophageal carcinoma, therapy of esophageal neoplasia, and eosinophilic esophagitis. And he has really focused areas in esophagus. I have another pleasant task to introduce another good friend of mine, Dr. Mohit Bhandari, and he's a bariatric and metabolic surgeon. He's the founder and director chief surgeon, Mohak Bariatric and Robotics Center, Indore, India. He's been widely acclaimed an accomplished surgeon having performed several thousands of bariatric and metabolic procedures in India and across the world. He is the first one to perform robotic duodenal switch. Duodenal switch itself a complicated surgery, as you know that. He has performed robotically. He has performed a large number of single incision laparoscopic surgery and specialized in banded bariatric procedure. He has published several of his observations in high impact journals and several journals concerned or oriented to bariatric field, and he is the reviewer in the obesity surgery and various other top-notch journals. Another good friend of mine, very younger colleague of mine, is Dr. Rakesh. And he's a very, very enthusiastic gastroenterologist and endoscopist. He's the director, Endoscopy Center for Obesity and Metabolic Therapy, AAG hospitals in Hyderabad. He has done advanced interventional endoscopy fellowship at Tokyo Medical University, published more than over 50 publications in peer-reviewed journals. He had received a Travels Award for ISNM at Korea APW, and he has received yet another award, Young Investigator Award, ANMA, that is Asian Neurogastroenterology and Motility Association. He has been a guest faculty at Asia Pacific Pancreatobiliary Endoscopy Future Forum, Tokyo, Japan. Now I have a very pleasant task to request Dr. and Dr. Mohit Bhandari to introduce the star speaker.
Hi, good evening, everybody.
Our star speaker, Professor Dr. Manuel Galvio Neto, whom I had interviewed during APW Calcutta. And he was very enthusiastic, energetic, and full of knowledge as far as bariatric endoscopy is concerned. And he is very handsome. Now I'll hand over the mic to Professor Mohit Bhandari, who is an eminent person in the field of bariatric endoscopy and surgery too in India. Professor Mohit Bhandari.
Thank you, Dr. Chandrasekhar, and it's an honor. I think I should thank you because you have given me one of the tasks which I love to do, which is an honor to introduce my own mentor. You know, when you introduce your mentor, it is not only a privilege, but it's a blessed day. So, ladies and gentlemen, I introduce to you who actually does not need any introduction, Professor Galvao Neto, Manuel, a great teacher, a great guide, a great friend, and most importantly, a great human being. Manuel is a scientific director at Endovita Institute in Sao Paulo, Brazil, and is an affiliate professor of surgery at the ABC College of Medicine in Sao Paulo, Brazil. He is a director of innovation at the International Bariatric Club. And those of you who would follow the International Bariatric Club, it's one of his brainchild with Harris Khwaja, and they've taken it to the international top-notch level. He's also the editorial board member for obesity surgery and surgical laparoscopy, endoscopy, percutaneous technique, bariatric times, and archives of gastroenterology. He founded the Bariatric Endoscopy Committee in the International Federation for Surgical Obesity and was the first chairman of this committee. He received the Surgical Innovation Award way back in 2015 by the American Society of Metabolic and Bariatric Surgery, an award which is a dream, which is an aspiration of most surgeons across the world. He's a committee member of SAGES, ASG, ASMBS, IFSO, and a fellow of ASMBS and ASGE. So ladies and gentlemen, friends, teachers, and colleagues, it's my honor to introduce my teacher, my mentor, Professor Galvao, who taught me bariatric endoscopy from the scratch. Manuel, the stage is all yours.
So thank you very much, Mohit. It's a pleasure and honor to be here I wanted to really deeply thank you, Professor Chandra Sekar, for the invitation. This is such an honor and such a responsibility to talk among you, and to thank my friend Mohit Bandari words. Just a friend can give such a beautiful words about someone, and I deeply thank you very much. And I hope to honor your words. And no further delays, I'll get into my topic. And so what is gonna be my topic is to talk about landmarks of the youngest subspecialty of endoscopy. Also, not to forget, because I can't, Professor Rakesh Kala, dear friend, thank you very much for the comments and to be here. So I will share my screen with you, and I hope you have it now. And the task is to talk about this. You see this plot of procedures called bariatric endoscopy. If you can narrow and close your vision into that, you're gonna see this stomach with a lot of pictures of different procedures. And the idea is talk about landmark publications. And the task that Professor Chandra Sekar gives me is to highlight landmarks. So the first thing is, what is really a landmark? So look at this view. A landmark is something that you look and see and defines it. And you know what? On my initial research, I find a true landmark. You see, that defines landmarks. You just need one picture. I don't need even to say to you guys what this landmark means, because it marks something and defines something, alters something, or change the wind on that. So my talk will be obesity, the worst disease of mankind, a chronic, progressive, incurable disease. And you see here, those words, obesity, diabetes, they were created by the World Health Organization. When they cross this path, we see the disaster and the epidemic that we are seeing right now that is going so hard, especially in some countries like India itself. And then to get on my topic, I have to get on that. This disease was neglected for so long that only a few years ago, gastroenterology, one of our major journals, get one specific edition dedicated to obesity. And what comes to me in my mind is this Acosta graph. I can call it mandala or a watch clock if you see that. So divide that in 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. Just follow me. So that starts obesity when you go from 12 to 3 o'clock, when you assess the obesity. So many causes of obesity, environmental, genetics. You see, you know more than me. Then we get to 3 o'clock, where after the assessment, we're gonna intervene. Clinical measures, medicines, behavior modifications, bariatric endoscopy, and surgery. And after that, we got to 6 hours. And then it defines that we have to do a lot of efforts to maintain the weight that the persons with obesity they achieve. And no matter what you do, because it's a chronic and evolving disease, you're gonna get to the ninth hour. And this ninth hour is that we're gonna have from 9 to 12 o'clock, we have to do our best to prevent the weight we gain. So that's really, really defining what is obesity, that we are not even prepared on the med school or in our education to define as a disease. And this is such a severe disease that's getting all over the world. Just look at the pyramids. This pyramid, of obesity with millions and millions of people. What you have before on the basis, diet, lifestyle changes, behavior modification. Then you go pharmacotherapy, and then you have to jump to the more severe obesity with bariatric surgery. And you see here, there's a clear gap in the middle that our vision is the bariatric interventions or endobariatric therapy can fulfill that now or on the near future. So what you have to offer to our community right now in 2020. So we have interventions on the stomach, as you can see here on those graphs. We have space occupying device, the balloons. We have device that occupy space in between the stomach and duodenum. We can also modify the anatomy of the stomach on its body by the means of suturing. We can alter the anatomy of the stomach by doing plications. And even we dare to part of the food that the patient ingests, we can take it out. And you can clearly see also a lot of red circles. Type it FGA. It means that they are clinically available as to use. Also, we have interventions on the bowel, like bariatric surgery. You see, that's quite some bariatric interventions, especially the most effective ones, that the surgeon intervene on the stomach and on the bowel. We already have that. We also have that in bariatric endoscopy. As you can see here, we can detour the path of the food from the stomach to duodenum by means using a PTFE sleeve. We can build a magnetic anastomosis and detouring the food into the bowl. And also we can modify the anatomy of the layers of the bowel, like the mucosa we are there. That said, we're still in the experimental phase of all of these interventions. So let me start with the landmarks publication, and I will start with a landmark publication on bariatric endoscopy itself. And what I have used as methodology to research on that, I went to Google Scholar, because now I guarantee you is the best tool to research, to beginner research, identify the procedure using keywords as medical as specific headlights subjects, or reverse search by the articles we have. So it takes me around 2 weeks to research on this whole presentation. Then we identify 2 most cited articles and publication, and I highlight one of those. Also, we identify at least 1 article publication with potential to be a landmark one that's not going to be in this presentation, but going to be available for the further reading on when the book comes out. So the first one that comes to me is this one from the ASGE Technology Committee. That is a systematic review and meta-analysis, and it was defined as what they call PV. And what is PV? I'm about to show you that PV is the technology that is used to define if a device can be used in a clinical practice. So it's a translational medicine approach to that. And you can see here the authors. We have Braham Abudaye from that's the leading author from Mayo Clinic right now, published in GIE in 2015. And this is a meta-analysis already cited by 223 sources. So what we have here. So first they define what is endobariatric therapy, what is primary, true primary obesity, intervention on individuals with BMI over 35, then it was reviewed later. And they have to achieve, and that's very important because this publication defines what we need to achieve with a new device in the area of bariatric endoscopy. So a minimum threshold of 25% of excess weight loss, it means around 10 to 15% of total weight loss measured during 12 months. In addition, the mean assessed weight loss difference between the primary endobariatric therapy and the control group, it means we need to do randomized control trials to get approval to that, should be a minimum of 15% assessed weight loss difference between therapy and control, and have to be statistically significant. Also, in terms of that we have a non-primary endobariatric therapy, like revising a bariatric surgery, need a minimum of 5% of total weight loss. And the risk associated with endobariatric therapies should equate to a 5% of severe cardiovascular events. So if we have an endobariatric therapy that proves to be significant impact on one or more obesity-related comorbidity, the threshold from 35 can be dropped to 30 to 35. BMI. So this is very important because this is a statement in the guide that still defines what is needed to achieve if you wanted to have a procedure or a device on endobariatric therapies to see the light of clinical use. So you see here, in this PV also, they studied two procedures that were at that time being used in worldwide: the intragastric balloon, the oldest endobariatric therapy, and the endobarrier that provides the detour on the food from the stomach to the proximal bowel by means of a sleeve. So see here, at that time, they studied 754 papers, and they end up with 82 papers on a specific balloon called Orbera, and 13 more among different types of balloons. And they could devise here the adverse events and efficacy and things like that. And you can see here from all over these studies that they could follow up to 12 months of Orbera. They can clearly define, if you go here around the losango of meta-analysis at the end, in the bottom of this graph, you see around 25% assessed loss. That means they achieve the threshold of the PV study. And also, when it studies in randomized controlled trials, you can see here that there is a clear advantage. If you see the middle line, and the losango, a clear advantage for the intervention group when compared against the controls and shams. The other one that was advised or was studied was the endobarrier. 135 studies were on the beginning, end up in 9 that changed H1C, and the others of weight loss. And you can see here on the top upper part, you can see here the ones with 1 year after, and you can again you see that the losango of meta-analysis bends to the right, achieving what is the threshold of 25%. And also in the lower one, the randomized controlled trials shows a benefit when you use this device. Both of the device studies, balloons and the sleeve, achieved also the threshold of not having more than 5% of severe adverse events on that. And also here, because this sleeve intends to treat diabetes, meaning significant comorbidity. In terms of H1C, you can see here that on the bottom, and the losango of meta-analysis, they go to a drop of H1C with around 1.5, again, achieving what the PV standards define to that. So this is the basic standard here. Another way to see that in randomized trials with targeting H1C for diabetes, again, they completed it there. So with that, we jump on the procedures itself. So the very first landmarks of ASGE define what we need, and also it guides now the FDA. And you can just resume that in the 5x5 rule. It means you need to achieve at least 5% of total weight loss with no more than 5% of complication to get approval by FDA, at least to be considered to get approval. So in terms of intragastric balloons, the oldest in the bariatric therapy is meaning that you put something to the mouth and get into the stomach, you blow it or you insufflate that with liquid, air or gas. It stays for a while, 4 months, 6 months, 1 year, and it occupies space on the stomach, so patients eat less. And after it's service time, it have to be removed. In general, you go there, you puncture, you empty, you remove by mouth. And the newer ones, you don't even need to do that. So just ingest, fill it, and then it go empty and pass through the bowel. So this is the types of balloons we have approved. And again, applying the PV bar have to pass. So our bar is very high. So it should be efficient in terms of weight loss, and we cannot have complications. And we also need to do a randomized control trial to get approved. So very few of the devices and procedures needs to do that to be applied in clinical practice. So the bar on and obesity is very high. So you have the ones liquid filled, gas filled, the ones that occupy space in between the stomach and the duodenum. They are FDA approved, those three ones. And the bottom ones, they use it worldwide, but still not approved by the FDA. They send, they already finished the trial, and they're waiting for the approval to be done or not. This is the adjustable balloon. You can see here the tail, so put the balloon, inflate that, and during the period of implantation, you can go there, get this tail, take out of the mouth, downwards, upwards, whatever you need to do. And also on the inferior right quadrant, you'll see here the balloon that you're gonna swallow. Then you're gonna put it liquid, that's trin solution, 550 cc's, and after 4 months, you're gonna like empty and pass through the bowl. So it's a new one on the PV bar. So what is the landmark paper that I found on my research is this one, that is a meta-analysis. And this meta-analysis was done, you can see in 2008, and was cited by 419 sources as further as this week. So you can see here what these 3,429 patients, 213 papers, studies, 196 were rejected, 16 left at the end, 2 RCTs and 14 series. But you can see here that this was 2008. From this one to our actual period, more than 20 other meta-analyses were done. But these specific ones, they define the quality of the papers of assessment. They got it here, the low publication risk bias, and the early removal rate of those balloons were 4.2. And interestingly, it keeps on the further meta-analysis that were published. And you see here all of the complications. We can discuss it later. The balloon can give it, and the mortality, very low one of 2 patients in more than 3,000 patients. It's 0.1% mortality. So it's a very low mortality, and also all the complications are related to this. So, and then this is a very interesting here. You see this graph that goes in this, what the numbers of studies, the number of groups, and the patients. And you can see here the BMI drop of 5.7 points. That really shows effectiveness of the balloons, and excess weight of 32.1%, analyzing all the papers available at that moment in the literature. So, and this was the first one was a single series, and this one is about randomized ones against placebo. And again, you see here at the very end, 2 studies, the number of patients 36, control 39. You can see here that also there is a positive, even a randomized trial, drop on BMI and excess weight against the placebo group. So this defines, that's the landmark paper. And you see here that's the oldest endobariatric therapy, 20 years on the market. You expect 10 to 14% of total weight loss. Is safe from 4 months, 6 months, now 1 year. Approved all over the world. More than 6,000 patients done worldwide. Selection, most of the countries over 27, US specific 30 to 40, and the targets should be 27 to 32, 33 on that. And then have this new kid on the block. There's a possibility of suturing the stomach, altering the anatomy, and is being used using now in clinical practice endoscopic sleeve gastroplasty. And this is a very brief video on how we do that. So using a suturing machine, and we're gonna act into the gastric body in a way to tubulize that. So anterior wall, greater curvature, posterior wall, we do different suture patterns. It is not defined we should we do that, but the important thing is you can alter, as you can see by your own eyes, we can alter the anatomy on the stomach, on its body. So reducing the volume of the stomach, inducing weight loss. And just briefly how it's been done, I'm just gonna show that because it's very like a novelty. You can see here that the act of performing suturing by endoscopy, so we're on our dreams, and now we can do that in a very standardized fashion with very natural movement. improvements, as you can see by your own eyes. So what is the brief timeline of this procedure? So we started in 2012, 3 groups, one with us in Panama, then was Mayo Clinic and Harvard at the same time. They started first publication by Mayo Clinic, then very rapidly, you can see here, first series, first international series. 2017, we have the first gigantic series of 1,000 cases, 11 meta-analyses. Our group just published 1,800 cases on the Brazilian on the Brazilian consensus. There is an India experience published by our friend Mohit, and as we speak, we are already doing randomized trial. But what is our landmark paper? Is this one? That is the first international series with us in Spain, Brahma Budaye group in Mayo Clinic, and Rin Sharaiva in Cornell. And was interestingly to show to you that this paper is already been cited 138 times, and it's just a series of international centers. And you can see here on the upper part that these 100 patients, and the most interesting thing to see is that the 3 centers were doing that in a different way in terms of suturing. And there was no statistical difference between the centers. And at the end of 2 years, this group got 2% complication rate in terms of severe adverse event, no mortality. Complications were 1 or 2 abscess, they were treated conservatively, 1 bleeding, treated conservatively, 1 pulmonary embolism, treated conservatively. And this group achieved an important landmark of 18.6% of total weight loss at 2 years, with 84% of those patients reaching at least 10% of total body weight at 24 months. So this is the landmark paper of this. And that is not a paper, but it's a landmark that is the study being done. Actually, the now is a running study that is a randomized control trial, FGA trial, to provide level 1 evidence. And you can see here the importance of this trial. That is, you have to see the participants, Mayo Clinic, UT, Cornell, Harvard, Chicago University, Hopkins, and some private centers on that. So the idea is to do our RCT, 200 patients, 80 going to be randomized to the procedure, 120 to diets. Then the diet will be crossed to the procedure will be crossed to observation, and to see if you need resuturing or other interventions. So 8 years down the road, 15 to 20% of total weight loss is a safe 1 to 3 year data. Now Cornell have one paper of 5 years, is approved around more than 15,000 cases done worldwide, in Asia also on that. Patient selection 30 up, targets 30 to 40 BMI. Also, we have this one that is the aspiration therapy. It means you can clearly see here, looks like a PEG, patient ingest, and 1 or 2 hours after they go aspirate part of they have ingest. So, so lowering the amount of food ingested by the patient. So this is the landmark paper, sorry to that. And this is a randomized controlled trial, a US trial, a pivotal trial that was already cited by 105 sources and was done in 2017. And you can see here the device itself and the patient, and it's on the paper. So after the meal, they go there, wash it, and they are able to eliminate part of what they have ingested. So very important on that is this graph. So you can clearly see here that's a total weight loss graph. So on the left, you have 14.2% on the completers and against 4.9% of total weight loss of the patients sent to diets. And also you can see that on the area under the curve graph, the far right on the completer series, and you can compare the patients on clinical treatment against the intervention. So they really have shown it all. So the clinical success is good. The clinical acceptance, not that good. It's clinically available, but not that much experience, still gaining momentum to do that. 5 years down the road, 15 to 20% assessed weight loss, safe 1 to 3 year data, but just around 1K done worldwide. Patient selection is interesting because it is targeted to a more obese patient, 35 and up, 35 to 50 BMI. So this is a very interesting way to see this endobariatric therapy. Also, we have some, like this what's called Pulse One. They use a machine to produce plications on the fundus and on the antrum. It was very well evaluated. End up on an FDA trial that I'm just showing to you. That's their landmark publication, a randomized sham control trial called Essential Trial. It was a pivotal RCT cited by 74 sources done in 2016. And interestingly, before that, even with an randomized control trial in Europe against diets, they achieved success. This one was a randomized control trial against the sham group. So you can see here the device, how do we to do the applications on that. And this is the enrollment and that in intention to treat publication. So on down, very down the graph, you see the analysis. The per protocol population of the treatment 213 against 106, almost 2-to-1 randomization against 106 on the sham group. So this is the result, and unfortunately, you see remember the PV. That's how important it is. So they didn't reach the bar of PV. They didn't reach the bar of the weight loss. And interesting, before that, all the single arm trials and even this European randomized against diet, they achieved 14, 15% total weight loss. But specifically on this one, they just achieved 4.95% of total weight loss against the sham group that reaches 1.38% of total weight loss, a difference of 3.55. So not even enough to reach the minimum threshold or PV or an FGA. So this procedure was not approved. And you can see here, used it clinically for 10 years in Europe and Middle East. At that time, 10 to 15 total weight loss, but now we put an interrogation mark when it compares in the randomized session with sham. It is safe, fail the FDA study. And then it jumps using the same device to what is called now the Pulse 2.0. And there is no really landmark paper, but the landmark should be the first on that. So the one called Pulse 2.0, a landmark paper that we can find, and it's going to be potential and not per citation for sure. In this one video, now there's a first series published or presented in DDW for patients. It's just a feasibility video cited by now 6, right? Not 3, 6 sources. You can see here those plications in the middle, how it ends in the interesting X-ray at this one at 6 months on that. So we have to collect data. And this data is being collected, led by Braham Udaye Clinic, Mayo Clinic, that is running an FDA trial to reach or to be evaluated under the PV and FDA standard. That so it's 2 years that people are doing that, but they approve it to be done in Europe, specifically in Spain, in Italy, and they are showing 15 to 20%. We have to really see what's going on. That's still experimental for US. And this one. Also here, in India, the Pulse has been doing by our friend Rakesh Kapala. Also, this new one is called Endomina, is another type of suturing, and they just published. That's the landmark publication per potential, not per citation, because it's 2020. It's so much new, not yet cited, but it's a randomized controlled trial published in Gut. And this is a different machine. They don't use specific endoscope. It is a specific device that you can put your endoscope inside, and you are able to do suturing in a specific pattern that is showing that on the graph. So you can see here is a very interesting graph. I love those kind of graph of a randomized trial with crossover. And you can see here, we explore that the total body weight loss one. So just follow in red. So this is the patient randomized to diets And they see here that the diet work a little bit, but when the intervention comes at 6 months, they come from 2.7 total weight loss to 10.9 total body weight loss. On the other hand, if you follow the blue line, you see that patients with they want randomized to procedure itself, they effectively lose weight up to 11 total weight loss, and they got a 12-month with 11.9. And then there's just one group to be followed, and at the end of 18 months, the average was 11.5% of total weight loss. So it's promised when we have to see. They are 5 years in a row. They approved it to be done in Europe and some countries. Also, I think in India, Rakesh have done quite some cases on that. Selection is the same, 30 BMI, targets 30 to 40 BMI. It's showing to be safe. When I say safe, gentlemen, it means that they are below the threshold of PV and with no mortality related to them on that. And now we got to this, you remember the first PV, the duodenal bypass liner called endobarrier. And the landmark is this randomized trial from 2008 that was seated 197 times. We were part on that first in human trials as well. So you can clearly see here at up to 12, in this time 12 weeks, that's a clear difference between the blue and the red line, meaning the device subjects and the diet subjects. So this procedure, more than 70 papers were produced over that. And we have to continue. It's not a landmark paper again, but it's that going to the FDA, look what happened. It's called this paper, this trial, is not published. It's called ENDO, and it was terminated due to higher than anticipated rate of hepatic abscess that was not seen in Latin America, not seen in Europe. And you can see here they have 3.5% of liver abscess when compared, but this trial had to be interrupted for safety reasons. Even with the interruption of just third of patients enrolled, you can see here the red dots and the blue dots. So you can see if you focus on the blue dots, inferior left quadrants were patients that effectively lose weight and drop H1C. So pretty much it was on hold and stopped for the hepatic abscess, but the company just recently get another chance. They're running another trial, not for 12 months, but for 9 months as well. 10 years, weight loss up to 15%, drop of 1.5% of H1C. We're supposed to be safe, but to solve the trial, that is not. Still experimental. We need to see what's going to happen in the FDA trial. And this also, the new kid on the block is the possibility of lift and thermically ablate the mucosa of the duodenum with intention to treat diabetes and metabolic conditions. The landmark paper is this one published in Diabetes Care, and it reflects the first in-human trial that we did in Chile. And you can see here, first in-human case series already cited by 104 sources since 2016. And you can see here from left to right, the mucosa, normal mucosa, then the mucosa lifted on the middle, and just after 1 month, lifted and ablated in the middle, then after 1 month or 3 months, it looked like normal. So you can see here, this graph shows to us SS and LS. SS is short segment ablation that we did at that time per protocol. There was one balloon length around 3 centimeters, and long segments more 10 or more centimeters of ablation. And you can clearly see the difference in between. The long segment is much more effective on that. Also saw that patients with higher H1C before had a best performance, and patients that we keep the medicines safe, they had a better response. On the road, more trials were done. Now we're doing our prospective randomized controlled trial done in Europe and Brazil. And again, that is Christoph Thompson leading the FDA pilot trial and pivotal trial to gonna be followed. So you need information from that to see it's gonna be in the clinical practice daylight. So again, it's the clinicaltrial.org. The register you will be waiting for that. 5 years is not for weight loss, it's just for diabetes. And now they discovered that have a very good impact on liver, fatty liver and FOG. And they'll be using to that. Still experimental, need to see the FDA study. And we will end with this one, is that just blow my mind, and possibly yours, the possibility of performing a magnetic anastomosis by means of endoscopy. So it's an internal bowel detour from jejunum to ileum on that. And this is the landmark paper, gentlemen, that was just the first in human study in 10 patients, seated for 61 sources already since 2017. And this is the idea, is to have these magnets, they can pass through the working channel of a pediatric colonoscope. So you go by mouth and then you go per anus. So you intubate the ileum 70 centimeters and you pass the triangle 50 centimeters. So you get your drops on. So you expose the magnets, they're gonna form an octagon that can be controlled outside. So just look on the picture on the right, that the anastomosis is patent and very well done. So this first 10 patients, you can see here 12-month graphs, and follow the weight loss of 14.6% in light yellow at the end of 12 months, and the H1C reduction in pre-diabetics and diabetic patients, very effective. All those patients were followed for 3 years for the publication, and they keep the H1C drop of 1.8, and the weight loss reaches 18.6 centimeters. And again, a landmark that will be is the new trials that be done in Argentina. And the previous papers proved feasibility, but then we went to more patients in a randomized fashion. It was discovered that it takes too long, 4 or 5 hours, and it's very experienced endoscopy to be done. They get back to the lab, and then they got with this new option that is laparoendoscopic. So do a laparoscopy, you grab the bowel and the ileum and pass the scope into the duodenum, open the magnets, liver that, and then gonna form the anastomosis. So it's the new one. So with that, I will rest. This procedure have 3 years, is up to 18% total weight loss, a drop of 1.5 points of H1C, is safe, experimental, it's on its infancy. So this is what I have to present to you, gentlemen, and I will gladly be here with you to further discussions. Thank you very much.
Dr. Mohit Bhandari. Hi.
Hello. Yes.
Mohit Bhandari would agree with me that is a fantastic lecture.
Yeah, absolutely.
So what we'll do is, if Pratik has joined, we'll just finish off the second paper, the presentation, before we'll take up questions on both the lectures. Is Dr. Pratik available? Hi. Hi. Okay, while he is joining, we'll take up some questions. Video. Others video. Chief, fantastic. I know it is very difficult to bring it down to 10 landmark publications. And you would have had 30, 40 papers. So it is bringing down to 10 landmark publications is a very difficult job. Now let's have some discussion before we'll move on to the second the paper. The first question is, we have around 42 questions here.
Oh.
So we'll take up one by one if time permits. So I want you to be little brief to the point. The first question is to Dr. Rakesh.
Okay, sir.
Their Orbira, Obalon, and Reshape Duo, and Reshuttle, everything is there. Which is your choice and why do you choose like that? Whom do you suggest balloon?
Yeah, the first to take the last point, a balloon, in my thoughts, is basically for people who are overweight and probably can stretch up to class 1 obesity, that is 27.5 or 27 to 35 BMI. Second, coming to the choice of balloons, actually, with due respect to all the companies, it's not like any specific choice. But off late in our practice, what we are doing is, in fact, we have a trial which is started in AAG, which is on a adjustable intragastric balloon, pre and post balloon insertion in patients with NAFLD, which includes a liver biopsy and other parameters. So my choice, if you ask specifically, of course, I used to use Orbera earlier a lot, but right now with the adjustable balloon, I am kind of going into that area because one thing is, as you've seen, a very practical problem in our practice is once you put in a balloon, if it is not tolerable, it's like an all or none phenomenon. Either you put it or take it out. But
You
the
mean a
advantage
sports
is
balloon you use it, huh?
yes,
Sports
patch.
balloon.
The advantage is if at all it's intolerable, then you take out 1500 ml and leave it. And if the patient has no desired weight loss, then after a couple of weeks, call him back and then put 1500 ml more. So
Any
that's
difference of opinion from Dr. Galvio or Mohit?
Yeah, so Manuel will tell his own experience. I think he has probably the largest experience across the world. But we, like Rakesh said, we were using Orbera previously, but I have completely shifted to SPARDS now because first it gives us the freedom of adjusting it, and second, it's a little more tolerable as far as we are concerned. Uh, in my own practice, I'm now completely an endoscopic sleeve guy. So after the endoscopic sleeve gastroplasty has come in and we have sort of started to achieve very good results with it, I don't see a place of balloon in my practice.
Mm-hmm.
They,
Oh, that's an important information.
yeah, because what, and Dr. Rakesh would agree, because now we have crossed around 250 endoscopic sleeves, so that learning curve is gone. And I think I'm able to give results almost like bariatric surgery with endoscopic sleeves. So patients don't want balloon. They want endoscopic sleeves. So balloon.
I agree with you, Mohit. Only thing is there are a subset of people, probably the, especially the young girls before marriage or, some of these celebrities. So in them, only the overweight category, between 27 to 30, 31-ish BMI. So there,
Another indication, Rakesh, suppose we're waiting for liver transplantation, you want to reduce 5-10 kilos, then you would not like to go for the endoscopic gastroplasty.
in
You would
fact,
go for the balloon.
yeah, we actually do this intragastric balloon both for donor and recipient. That's a very interesting thing. For the
Ah.
donor also, to cut down his weight because that will decrease his steatosis, we actually
So,
did in a couple of patients.
Mohit, do you agree there is a place for still a place for balloon?
Yeah, I think absolutely. In transplant candidates, we are still using balloons. We get those, and donor recipient, as Dr. Rakesh said, he has huge experience. I think that's the only area, probably transplants, and probably some patients who cannot even afford endoscopic sleeve, because I think the cost of putting a SPARS balloon is still less in India as compared to doing an endoscopic sleeve. So transplant and endoscopic sleeve would be my two indications. On non-affordability would be my two indications to. Also, sometimes, to be honest with you, a lot of surgeons ask me that if you do an endoscopic sleeve on the stomach, will you be able to convert it into bariatric surgery? I can tell you honestly, I'm more comfortable in converting an endoscopic sleeve into bariatric surgery than an intragastric balloon.
Mm-hmm.
Because I have seen some chronic problems with balloon, but endoscopic sleeve, you can take the entire thing into the specimen, and we never had
Let's
problems.
listen from master's voice. What is the master is telling? Balloon or no balloon? Or if so, what balloon? Or you straight away go for the gastroplasty? What is your take?
Well, thank you. Thank you for asking me. In Brazil, we have a very mature market. So we started 20 years ago. And with the introduction of sleeve gastrectomy, what we got from the balloons, and now we have like layers or steps. So balloons now, and we use balloon for even lower BMIs. Our Brazilian consensus with 40,000 patients indicates that we are safe to use balloons 25 BMI and over. So what we could do now, we are getting balloons to even lower BMIs. And then for the higher BMIs, we go with endoscopic sleeve gastroplasty. And as Rakesh and Mohit just stated, price. So price-wise, you're going to be indicating price-wise. And also if the patient have a specific test, like going to a marriage, like losing weight to fit in the dress, losing weight to get pregnant. So we work very close to the OBGYN guys and reproduction guys that you know what? This is much cheaper to put a balloon than to do an artificial insemination, and much more effective. And the efficacy is at least 10 times more. So nobody even knows that. So we are really growing that field. And for sure, and to let my friends Mohit and Rakesh know that in Germany, with Professor Zoran, and they have a series of patients for donors in kidney transplantation, and even to do in liver transplantation on the line, because those patients are kicked off of the waiting list if they go over 30 BMI. And endoscopic sleeve gastroplasty can be done even in patients with varices or whatever.
Okay.
So you guys can use that. NAFLG is very important to see, because Rakesh is very up to date, and I love how up to date it is. So the balloon just get an indication on IDE from FDA to NAFLG and NASH. And he's very up to date on that. And this paper from Brahma even got transgastric biopsies to follow that. And we know that's no treatment for NAFLG besides losing weight effectively on that. So that's, especially in India for you guys, that's a very good niche to explore.
What I learned from this discussion is there is a definite place of balloon just before pregnancy, before liver transplantation or a major surgery, or some logistic reason like unaffordability. And the other one is very important is someone waiting for marriage. And okay, now the pointed question to Dr. The Neto is, in magnetic anastomosis, there is a question from Dr. Prasad Chennai. Magnetic anastomosis, if jejunum and water bubble, or how are you sure that the anti-mesentery borders are in exact opposition?
That's interesting.
Bowel,
so yeah, it's a side-to-side anastomosis, and the way the magnets are built, if there anything in between, they're not gonna couple. And the way we couple that is outside, we have like a joystick. Inside those magnets, they form a round shape or octagon shape, and you have 2 or 3 sutures. And outside, you can extend and retract those sutures so you can align the anastomosis by X-ray. But let me tell you, this is extremely hard. Get into the Dobson and align that. So there was a drawback in the whole process. It is feasible, it can be done, but it takes forever and it's very difficult. Now with the laparoscopic and the laparoendoscopic approach, hybrid approach, so you can visually put them together and don't even need to do suturing, because in the bowl you have to puncture and put the magnet and open it. So then you align this puncture or this hole in the middle of the magnet to put them together. But
it's technically difficult, Chief. The magnetic anastomosis. Huh?
Not the magnetic anastomosis itself. The magnetic anastomosis is the easiest in the world, the safe in the world. But get to the drop zone, this is a nightmare. This is a nightmare. Imagine that you offend not one, but you offend 20 gods in India. Then this is how difficult it is going to be. Okay. But with this new approach, laparoscopic endoscopy is a 30 minutes procedure. And imagine that you can do like Rakesh and Mohit, go there, do the suturing. And then before that, you do the anastomosis. You know what's gonna have? You're gonna have a bariatric surgery. You're gonna have a procedure on the stomach, a detour on the bowel, and then you're gonna have the efficacy of the bariatric surgery, keeping the minimally invasive one. And when we have the robots to navigate and put those magnets in place, my friend, yes, this is gonna be a hit.
Mm-hmm. Okay. Another question from Dr. Prasad from Chennai. Quick answer from all three panelists who are doing endoscopic sleeve gastroplasty. How do you know that the depth of suture that you have taken up to cirrhosis or not beyond the cirrhosis or subserosal level? How do you know that? And what is the how do you assess it? Starting from Rakesh.
Yeah, the beauty of the Apollo overstitch is actually it's designed in such a way that the suture, the needle, the depth of penetration is fixed, and it's nothing like in your hands where you can really go in and then assess or gauge the depth.
So
So
his concern is, do you include the perigastric structures also?
no, we leave the fundus because there are the short gastric veins and arteries behind, and
Mhm.
start from incisura, come up to 5 centimeters below the GE junction, leaving the fundus.
So what is your take, Mohit?
Yeah, so I think the question here is that how to avoid an injury to the surrounding viscera. I think that's the core
Mhm.
question. So the best way to avoid injury to the surrounding viscera is what we learned in general surgery. As all of us know that we use a helix to pull the tissue towards us. So as
Mhm.
general surgeons, we were taught, Manuel, if you know, is an esophageal surgeon. So we know in general surgery we are taught that we need to respect the tissue. So when we pull the tissue with the helix, if the tissue is not coming to the surgeon and there is a tug on your hand, or you feel that there's a pressure while pulling the tissue very easily, it means you are in control of some surrounding tissue, maybe gallbladder or maybe small bowel. So the pull of the helix will give you an estimation as to uh, whether the tissue is coming easily for the bite or not. So the first trick here is that when you pull the tissue with the helix, make sure that it is very easily coming to you and you don't feel that pressure on your hands.
So the designing matters and helix matters. What about Chief? Your take. What is the
Oh,
advice to the exercise?
yeah. You know what? Rakesh and Mohit, they are bright minds. They just explained that in a very bright way. And you know me, I'm a very simple-minded man. I'm a plumber. So plumber-wise, I will concern if I have a problem. This is not a problem. So
Actually, the
what is the
surgeon were considered as
possibility?
carpenter, plumber.
Yeah. So what is the problem? Clinically, what's the possibility of you grab something that's significantly gonna give you a headache? 0.02%. So I don't have a problem.
Okay.
Yeah, there's one point about the tissue thickness. So I think the best way to assess the tissue thickness is that you have a blinding effect. If you take good amount of tissue, you won't be able to see it. There's a blinding effect there. I think there are ways to take good thickness, and I think that's probably the learning curve. I was taking very superficial stitches, and these are the ones which fail to create a fibrosis.
In fact,
I have my colleague, Dr. Satya, wants to ask you.
yeah.
He has got a question now. Yes. Yes, sir. Sir, in ESG, we are not excising the portions of the stomach. We are just plicating it. So what will happen to the secretory functions, the acid secretions, the chance of ulcerations and malignancies in the excluded portion of the stomach?
So I think that there's nothing which is excluded there. Even if you cover that thing, it's not excluded. You still have an access to it. Number one. Number two, as far as the secretory function is concerned, yes, the gastric acid secretion is a bit reduced because of the exposed surface area. So that secretion is reduced commensurate to the exposed surface area of the stomach to the food, maybe around 20%, if I would say. And the good thing here is that you always have an access to that area, unlike a gastric bypass where that area cannot be assessed till the time you make a gastrotomy and go inside with a scope.
Professor Galmo, pose versus gastroplasty. which is your choice, and both almost operating the same mechanism. What is your take?
Great. So first to start, I don't have this option yet. If I have this option, so because I don't have polls in my country, gonna start next year. So I have done cases out abroad. They work very differently. So the ESG is the one we know the most. We know the mechanism of action. Post 2.0, we are learning. So the trials done in AIG, in Mayo Clinic, and in US, gonna give us better idea. So we don't know how gun post 2.0 are gonna be in the future. What they have proved is that the applications with the post 1.0, they are durable. So if you want something to show to someone, like years down the road, the post 2.0 is gonna be there. The downside of these, that the conversion, as Mohit just said to you, conversion from an ESG to any bariatric procedure is an easy task. I am not sure about that with post, because those applications, they are made of nitinol, those baskets, and they're gonna stay there. So they're gonna have to be extra caution. One good thing is that as you're not gonna do the fundus, I guess the bypass is gonna be easy to do, gonna be a virgin tissue to handle on that. So that's have to be balanced. So if the projections that we are making, the assumptions that we are not proven yet, that the post gonna last more, so we're gonna have ESG for lower BMIs, post to higher BMIs down on the future. But again, it's just assumption that from this day that we are living right now, we cannot prove. But that's how my thinking is, my thought process.
So in your opinion, ESG is, if you want to add on some more procedure, it is reversible, easier to go ahead compared to post. I want to ask all the three panelists, is there any study available? Those who keep doing bariatric procedure, the surgeon or endoscopy, they look slim like all three of you. Mohit, Rakesh, and Professor Neto.
Yeah,
Is there any study available?
Yeah, there's a study. In fact, last year in IFSO, there was a complete session which Malfobi conducted. You know, Manuel, you would have remembered that session. So it was bariatric surgeons who underwent bariatric surgery. So there's a high incidence of obesity in bariatric surgeons. In fact, Rakesh would know that I was myself obese. I was around 100 kilos some like 3 years back. If Rakesh knows me, Manuel knows me, I lost a lot of weight, not by surgery, but by a lot of running. In fact, just before I'm traveling now, so just before this, I ran a 5 kilometers just before.
I think you have lost weight because of overworking.
No. Nobody loses weight because of overworking. It's a lifestyle.
Okay. The question is to all three of you, pointed question is LSG versus ESG, laparoscopic sleeve gastrectomy versus endoscopic sleeve gastroplasty. Which one will you choose? Patient ready for both the procedure, or what is the how do you choose this? Starting from Professor Neto.
Yes, I just wanted to, I will start explaining the difference. So I'll let Rakesh and Mohit carry on. So that's a big, huge difference. When you do a laparoscopic greater curvature application, so you take down all the vessels and nerves of the greater curvature, and the surgeon do a very good job on invaginating this tissue and creating exactly like a sleeve gastrectomy pressure environment. They create a high pressure, low compliance system. So those patients tend to have reflux, they can have leaks, they can rupture the suture and cause an hernia-like. So the ESG keeps a low pressure, high compliance system. So there is not a refluxogenic procedure. The possibilities of leak is very, very low, and ulcers and ischemia is very low. So with that said, I leave Rakesh in place with Mohit to explain.
Okay. And Mohit, what is your take? LSG versus ESG. You are basically a surgeon. You have been doing bariatric surgery. Now you are turned out to be an endoscopic bariatric endotherapy. You are doing more.
Yeah. So
what is your
double agent?
I have a very special place here because I have converted my endoscopic sleeves into bariatric surgery, and I have managed weight regain after bariatric surgery with endoscopic sleeve. So I know both the sides of the coin.
Wow,
Now,
that's why we want to have your opinion.
yeah, so now this is a very interesting question. Actually, I feel you have put a caveat here that the patient is ready for both the procedures. So,
Mhm.
I would definitely consider here certain important factors like the body mass index of the patient. So, I refrain from doing endoscopic sleeve on patients who are a BMI above 35 when they are ready as a candidate for bariatric surgery. So above a BMI of 35 with comorbidities, I definitely choose bariatric surgery as an option because I am a surgeon. That's like, and since you said that the patient is ready for that, again we have a very nice algorithm, and that's a separate chapter altogether. But that algorithm is fixed. The indications for endoscopic sleeves are just three at our center. Number one, a BMI between 25 to 32. I have done a BMI as low as 25 with diabetes and fantastic results with endoscopic sleeve. So BMI between 25 to 32 is number one indication. Number two, any patient who is not a candidate for bariatric surgery because of multiple abdominal surgeries done in past, multiple hernia repairs done, and there are a lot of them moving around the market. And
So you
it's
will decide on the comorbid disease and the previous history of surgery.
yeah, yeah.
Suppose comorbid disease and the previous surgery will go for endoscopy, or otherwise higher BMR you will go for laparoscopy. Is it like that?
Absolutely.
What
Yeah,
about Rakesh?
Yeah, so I just put it in two simple things. One, I agree with Mohit about the BMI. Anything more than 35 to 37, I think we have to push them towards laparoscopic surgery. And
Mhm.
second, more important thing, which I've seen practically in the past 150 to 200 of our series, is a motivated patient. Very important.
Mhm.
The patient is motivated, then probably ESG is a better option, even up to a BMI of 40. And if it is kind of a semi-motivated or unmotivated patient, I obviously ask them to go for a sleeve gastrectomy.
I think fantastic. Professor Neto said ESG is sometimes reversible. You want to add on some procedure. Professor Mohit says depends on the comorbid disease, and you also endorse the views. My tricky question here is patient doesn't want surgery. You want to bring down the BMI with a balloon. After that, you will do ESG. Such a procedure do you handle? So, what is your take, starting from Professor Neto?
Breaks the question. Can you repeat that again, just briefly?
A patient doesn't want surgery. He wants endoscopy procedure. BMIs are very high. Do you go for balloon to reduce BMI? Then go for ESG.
Well, that's a great question. In terms of if the patients, depending on what patient wanted, it is a bridge procedure. So the problem, the issue with balloons with the bridge procedure is that you put the balloon in, the effective lose weight, but the walls of the stomach get thick. So you need to remove the balloon and wait a little bit uh, to do the surgery. So in that time, patient gain weight. With an ESG, we don't have upper limits, and even we can offer the patient more durable weight loss. So nowadays, I go more for an ESG, but like impossible BMIs, impossible like 70, 80 BMIs, I will do a balloon first and then do an ESG. But again, our friends Ron in Germany, in Berlin, he has this group of patients that have no upper limits, and we are talking about German-like, so they are huge and big. And basically, if you got someone to do the anesthesia, we can do ESG, my friend at TS. We have done situs inversus, impenetrable abdomens, procedures that the surgeons say, I'm not going to go into that abdomen. We can go there. Balloon is in and out, but again, we have the problem with the wall thickness.
Okay, what about your experience? We have two more questions, bariatric, then we move on to the next topic, GRD. What about Mohit, bridge therapy?
Yeah, so as Manuel said, now the bridge therapy. If you have a transplant candidate, unmarried female, balloon is the option. But otherwise, endoscopic sleeve I prefer. And my experience is that when you do an endoscopic sleeve, and the patient loses weight, he gains more confidence in a bariatric program. So, there are surgeons and gastroenterologists across the world who are debating which is better, sleeve or ESG. I think it's not a question. To me, I started my bariatric endoscopy program and my bariatric work has increased. So patients, gain a lot of confidence after they lose a good amount of weight with endoscopic sleeve, and they love it, and they say, okay, now we are ready. You can probably, upgrade this procedure to a bariatric procedure. So you have to understand that there's a hitch in the family to get some intervention done. Once they get one and the patient loses some weight, they gain a lot of confidence. Also, Dr. Chandrasekhar, one thing I want all the gastroenterologists to know, because they deal less with obesity, they deal with, other. Uh, I can tell you that most of my patients, they lose most of their comorbidities like type 2 diabetes, hypertension, sleep apnea, lipid disorders with just 10% or 20% of excess weight loss. We don't require 100% of excess weight loss like bariatric surgeons. We require just 10, 15 kilos of weight loss to help them gain a good control of their diabetes, have a good control of their sleep apnea. So I think that's the way we should think. We should give them first this endoscopic sleeve and then, prepare them for upgrade.
Yeah, I agree with you, Mohit. I think 10%, the rule of 10 is 10% weight loss is good enough for all the conditions.
Absolutely.
And I think Manoj will agree with me that being a strong promoter of small bowel interventions, so the future is going to be a dual approach. You hit the stomach, you hit the small intestine. You put a duodenal sleeve in the duodenum and a gastric sleeve in the stomach, and that's going to be at par with any of the bariatric surgeries.
I agree. That's why I'm here.
Okay. Before my colleague asked question, there is a diabetic patient, cirrhotic, NASH related, and what kind of approach will have that? This is a full-blown cirrhosis, overweight, NASH. What kind of bariatric therapy you would like to advise?
So I think if a patient has full-blown
This
cirrhosis.
is a question from Dr. Gokul.
Yeah.
Chennai is asking this question.
So Dr. Gokul, my answer would be that if you have a patient with cirrhosis, I think mostly these patients with full-blown cirrhosis are having esophageal varices. So the first thing we need to do is that rule out that if we have gross esophageal varices or, what's the Child-Pook's status we are dealing with. With my personal experience, I usually would avoid doing an endoscopic procedure here on severely cirrhotic patient. I do a simple sleeve gastrectomy and I come out of it because I feel sometimes I have damaged esophageal varices with my double lumen scope. I'm a little concerned because they sometimes bleed because we pull in and put the scope. Also, I think these kind of candidates with full-blown cirrhosis, probably they need to, we need to probably ban their esophageal varices and rule out if they have some gastric varices. And if, it becomes more difficult in such cases. But I have, for patients who do not have gastric varices, just the esophageal ones, we have done straightforward sleeve gastrectomy and they have done wonders in these cases. But I avoid endoscopic procedures with active esophageal varices. And if there are no esophageal or gastric varices, you can do anything. You can do an endoscopic sleeve, you can do a sleeve gastrectomy. Even some patients you can put in a balloon and then later on remove it. So that's my take.
I think the last question will be from Dr. Satya, the organizing secretary.
To Professor Galvo, sir, you have introduced an endobariatric technique called duodenal bypass sleeves. So, how long that sleeve to be kept there, and how effective is that method, sir?
That's a wonderful question. Thank you for asking. The sleeve itself, it is made of PTFE Teflon. The sleeve itself is harmless. It can be there indefinitely. The problem is how to, and Rakesh is just watching me with good eyes, is that how to keep that in place. So we have tried with barbs, 20 barbs, 4.5 millimeter barbs, post-pyloric, stays in place, but then it leads to complications. All the stains have it, that is bleeding, dislodgement, perforations, hepatic abscess. And then you say, okay, no barbs, so let's go with transpyloric, and then you're gonna have what? Migrations. So we are trying to find the good middle ground of what's not gonna cause harm and gonna stay in place. But we're not talking about the sleeve itself. We're talking about the fixation methods that we still are working on that. When we got there, and if you got there, please tell me, this is $1 million question, that we're gonna have the perfect procedure.
Thanks.
True.
I think you would agree with me that a fantastic discussion and a fantastic 10-mark publications and bariatric endotherapy. Professor Galvio, thankful for the wonderful deliberation. I thank my moderators. But most of the endoscopy procedure, bariatric procedure, lead on to GERD also. So I request all of you to stay with us, can contribute more to GERD. Rakesh is smiling at me, I know what does it mean. And we are going to have a fantastic talk by Professor Pratik Sharma. He's a great speaker. He's an authority in GERD, and is going to be moderated by another eminent physician, Dr. Prasad Iyer. Dr. Pratik Sharma was busy with so many webinars, so he found time now, and I'm very grateful to Dr. Pratik Sharma. He will be properly introduced by Dr. Prasad Iyer, who is another eminent physician. 1 minute, Dr. Pratik, 1 minute, just we want to. Okay. You're just checking his slides. Pratik, how are you doing?
Very good, TSC. Good to see you in the hat there.
I was wondering that you will make this comment. How are you
We
doing?
are the ones losing hair. How come you're the one wearing the hat?
No, we just came from the theater.
Okay.
Okay, Prasad.
Hi.
I will hand over the mic to you, Prasad. Okay.
Thank you. It's a pleasure to introduce Dr. Sharma, who's I think really needs no introduction. Dr. Sharma, as you can see on the slide, is a professor of medicine at the University of Kansas in Kansas City. He also heads the VA in Kansas City as well. He has been in the upper GI field for probably the last 20 years and has published several landmark papers. I look forward to his presentation. Welcome, Pratik.
Thank you.
While
Thank you,
Pratik is
Prasad.
coming, I just want to tell you there are two stalwarts who have really made India proud. Both Professor Pratik and Prasad Iyer. And Pratik has done enormous work in GERD and the Barrett's esophagus. He has contributed richly to Indian Society of Gastroenterology as much as Dr. Prasad Iyer also. And despite his busy schedule, both of them agreed to be here. And we want to listen to the great presentation from Dr. Pratik Sharma. Yes.
Okay,
Can
TSC, can I
slide.
share my slides now? I'm guessing yes.
Yeah.
Okay, it's good. Can all of you see it, Prasad?
Yeah.
Okay, perfect.
We could see and hear you.
Okay, wonderful. So firstly, of course, my thanks to Prasad for the introduction and for being here as well. And, I think we learn as much from him as the others during the panel discussion. And of course, to TSC, not just for today's session, but just how his brain works in coming up with these wonderful ideas, including this one about the 10 landmark studies. And I have to say that I had to go back into the 1930s and pull out some articles, which I had forgotten as well. So I learned during this process while putting together this presentation. So TSC, again, thanks for this opportunity and for continuing to make these outstanding changes in how we deliver education. So this is, the task I will take both for Barrett's esophagus and reflux disease is I'll talk about when were these diseases first mentioned, what is their pathogenesis, their diagnosis, the definition and guidelines, any classification systems, and then what's the treatment in that. And rather than take it through each one of these topics separately, I will put this in chronological order. And some of the things may change because of the chronological order, which I found very interesting, is that sometimes a treatment came before the classification. And so you always wonder, what were we thinking? But I think, these landmark articles also put things in perspective. So let's start first with Barrett's esophagus and then with gastroesophageal reflux disease and go in that order. So I thought it was important to share this landmark article because this is what caused the name Barrett's to stick with this disease. And this is Norman Barrett, and I have to admit that he was a surgeon. So even as gastroenterologists, we are the ones who are very much interested in this disease. This was actually described by a surgeon. And he described this as a chronic peptic ulcer of the esophagus, along with quote unquote esophagitis. So he thought that this was still an ulcer, just like a peptic ulcer occurring inside the stomach. That was an ulcer occurring within the esophagus. And that's where the term Barrett's esophagus stuck. But he was actually a little bit incorrect about the definition. And so he proposed this idea that this was likely that the stomach was in the mediastinum and that these patients had a short esophagus. So he did not believe that this condition was in the esophagus, but it was actually part of the stomach, which was herniated into the mediastinum. But after that, in 1953, is when I would say the more contemporary or definition or diagnosis of Barrett's esophagus by Allison and Johnston, also surgeons, back in 1953, in which they proposed this theory that this was not the stomach, it was truly the esophagus, and this was abnormal lining of the esophagus with columnar mucosa or gastric type mucosa. So this is actually the first description of a columnar lined esophagus in the 1950s. Finally, Paul and Jerry Trier, they published this landmark article in the New England Journal of Medicine in the 1970s, in which they described the histological spectrum and first showed that a columnar lined esophagus could be associated with dysplasia. So the description of intestinal metaplasia, which is what we use in the definition of Barrett's esophagus today, and dysplasia occurring within Barrett's esophagus, I mean, this is all from this article in the 1970s from the New England Journal of Medicine. So those are things which I felt did lead to this. Then in the 1990s, jumping ahead, we were able to show that the Barrett's mucosa could be resected. And this was by Haru Inoue. And he introduced this cap technique for resection, in which you can see that there is a tip at the end of the endoscope, and you have a hexagonal snare which goes through the side, and then you can inject, suction, and resect. And he showed that this could be done for esophagus, stomach, and colonic lesions. And I think this was a landmark paper because this was the first time EMR was performed on patients with high-grade dysplasia in the esophagus. And the technique has evolved, but the concept still remains the same. And resection is now a critical part in the treatment of patients with neoplastic Barrett's esophagus. And this was the paper which led to that. And this is what we are seeing is using now a high definition endoscope, the same CAP technique proposed in the 1990s early on for a T1A Barrett's adenocarcinoma. And we've injected the lesion, raised it up, and now we are using the CAP technique to resect this lesion. And with this, you're resecting about 2.5 centimeters of area. And this is something that would not have been possible unless for this landmark article, which was published. Right back to back after that resection technique, there was an interest in mucosal ablation of Barrett's esophagus. And Dick Sampliner, my mentor, and Gene Overholt, roughly around the same time, proposed photodynamic therapy and multipolar electrocoagulation for ablation of the mucosa, not resection. And this was done initially using a balloon and the injection of porphyrin sodium. And this led to ablation of the Barrett's mucosa. So this was the first, landmark study showing that Barrett's mucosa could be successfully ablated. And by successfully ablated means that it was then replaced by squamous mucosa. So now the columnar lining is replaced with normal squamous mucosa or neosquamous mucosa. So this is the first ablative technique published to reduce the surface area of Barrett's esophagus. So this is interesting. Now comes the guidelines. And I picked this guideline by Dick Sampliner again for number one. This is a tribute that I can give to my mentor who taught me all I know about Barrett's esophagus. And this was also the first time that, he single-handedly through the American College of Gastroenterology put together all the published literature and gave us very important, definitions of Barrett's esophagus, what therapy should be used, i.e. PPI therapy, and what should surveillance intervals be. And before this landmark publication, none of these had ever been put together by an association, by a guideline, or by a group of experts looking at this. And so this was in 1998 since this has happened. After that, the guidelines have revised multiple times. Prasad has published the most recent guideline. So they've evolved, but this was what led the concept that guidelines in patients with Barrett's esophagus. So first set of management guidelines, nearly 50 years after the description of Barrett's esophagus, first by Norman Barrett and then by Allison and Johnson, which was done. So this was the first ACG guideline. Then moving forward comes how to grade Barrett's esophagus or a classification system in Barrett's esophagus. So pretty much you could think that we are working backwards in a way, that we've now defined Barrett's, we are telling how to treat them, how to ablate them, yet there was no standardized way of looking at Barrett's esophagus. And this was through the International Working Group for the Classification of Esophagitis, led by John Dent and Lars Lundell, in which we looked at the CNM classification to describe the extent of Barrett's esophagus using this. And these Prague criteria were published so that we can have a global language wherever we are practicing endoscopy. If you see Barrett's esophagus, how can you describe it in a way which makes a sense, both from a scientific perspective as well as from an endoscopic perspective. Moving along, the initial PDT, because of side effects, did not stick around for a long time. And then we came up with the New England Journal of Medicine article using radiofrequency ablation, showing that, again, not a new concept that ablation works, but just a better randomized controlled trial. So again, showing that RCTs can be conducted in this patient population and showing that RFA was better than not doing anything. Similar concept to PDT, but again, a multi-center study and showing that Barrett's esophagus can be ablated using this. So a successful ablative technique in the eradication of dysplasia and intestinal metaplasia in patients with Barrett's esophagus. Next comes the classification system or diagnosis of dysplasia. using narrowband imaging or virtual chromoendoscopy after high definition white light endoscopes. This was the new wave for the future, showing that these endoscopes could tell us about the pit patterns seen in patients with Barrett's esophagus. And a number of publications came along telling us that this worked. This is just a group that we put together of experts, 6 experts around the world, who looked at the Bing classification and showed that virtual chromoendoscopy could be used as a diagnostic technique to characterize high-grade dysplasia and early adenocarcinoma in patients with Barrett's esophagus. So this is what happened with this thing. So since I was limited in how many I could present, I'm sure that I have left off a number of important Barrett's articles, which we can discuss during the Q&A session. And I'm sure I've not done due justice to a number of experts in the field, including Prasad for this matter, but we had to just choose about 4 or 5 in this field and the remaining for gastroesophageal reflux disease. So similar concept for gastroesophageal reflux disease, and this is a paper on peptic esophagitis, which was described first in the 1930s, published in JAMA, of that there was something wrong in the esophagus from acid reflux. And so this is the first time a description of GERD happened. And this was described as peptic because it is related to acid. And then also they went on to propose a milk drip for its treatment. So you can see that people were as smart, if not smarter than us back in the 1930s, despite having very limited resources and just by their very astute observations. So this is probably the first description of gastroesophageal reflux disease in that time period. In the 1950s, now an operation was proposed for it. This is where we get the famous Nissen fundoplication, which is done even in 2020. So you can see how some of these stalwarts and these landmark publications have stood the test of time. And this is a standard procedure. There are minor modifications. For example, the degree of wrap can be changed, the number of sutures, which Nissen proposed, can have been reduced, but the concept still remains the same. So these to me will be truly, landmark publications, which cannot change even after 50, 60 years of research. So Nissen proposed that fundoplication procedure can help reduce reflux-induced esophagitis, which was being done at that time. So again, concepts which are here to stay, and this is what was done. So after surgery comes medical therapy. And again, this was a learning point for me, is I didn't realize that. So when I was digging through the literature, this is Dr. Black, who went on to win the Nobel Prize for his work both on beta blockers and H2 receptor antagonists. And he published the role of H2 receptor antagonists in reducing acid. And this is also therapy that we still use for patients with gastroesophageal reflux disease, so from the 1970s, which was done. So role of H2 blockers to reduce acid production was identified back in the 1970s. Following that, we had ways to measure esophageal acid exposure. A study from the 1970s by Johnson and DeMeester. So remember this, we talk about the DeMeester score in 24-hour pH monitoring. That's where this comes from. Larry Johnson, Tom DeMeester, again, surgeons, but looking at how to measure acid exposure in the esophagus. This was, of course, done by catheter-based pH-metry, and they demonstrated a way how we can measure and evaluate acid reflux, and we still use this in our patient as to what is the acid exposure level that we are facing in this patient population with gastroesophageal reflux disease, and this was demonstrated then. PPIs, something which is standard of care today. Omeprazole, first described in this publication in 1984 in gut, as to what's the effect of a single and repeated dose of omeprazole on gastric acid and pepsin secretion. And this was, you can see, done in Scotland. And this showed us that decreased acid output after single and repeated doses of the first PPI, omeprazole, happened. After that, clinical trials were conducted for healing of erosive esophagitis, finally leading to a meta-analysis in the 1970s by Richard Hunt's group, showing that PPIs were superior both to placebo as well as to H2 receptor antagonists for healing of erosive esophagitis. So that was a landmark study as well of a meta-analysis, but this is, I went back to the source of what really shook the world in terms of gastroesophageal reflux disease treatment. And now we come to why reflux happens. So again, in a way, working backwards is that after we've shown that PPIs can help patients with reflux, John Dent, Richard Holloway, and Jim Tooley, again, a surgeon, and Dodds, a radiologist, you can see how this group came together and showed that incompetence of the LES, or lower esophageal sphincter, was the primary reason for gastroesophageal reflux disease to happen. So all along, it was thought that GERD happens because of large hiatal hernias or only because of a mechanical incompetence. But now we know that the major mechanism for upright GERD, and in the majority of the patients, is because of transient LES relaxation. And this was a landmark publication by Dent and colleagues in Gut in 1988, which showed that this was the mechanism for causing gastroesophageal reflux disease. After that, again, the IWGCO, which I showed you earlier for the Prague classification. This was the initial group which got together to publish and validate the endoscopic classification for erosive esophagitis, which was called the Los Angeles classification. And this is still what we use in practice, or should be using in clinical practice, rather than saying mild esophagitis or moderate esophagitis, which to me is meaningless. I think you need to use validated terminology. And this is the LA classification of grade A, B, C, and D erosive esophagitis, published again in the late 1990s. And this group developed a classification system which was related both to esophageal acid exposure, heartburn severity, and more important, they were able to link it to treatment outcomes, meaning LA grade was easier to treat with PPIs, LA grade D was much more difficult and had lower rates of healing of esophagitis in LA grade D patients. So again, one of the landmark publications in patients with gastroesophageal reflux disease by this group. The next is, again, just as I showed the RFA and the PDT papers, I picked this paper by John Pandolfino, Joel Richter, and Peter Kurylas on wireless pH monitoring, not because it's a landmark paper on pH monitoring, which has already been done, but this was just a much more user-friendly way to do it. And rather than being a landmark publication, I think it has been impacting our clinical practice in a landmark way. So the concept was old, but the way it was presented was new, that we can do this without a tube sticking out of your nose that a patient has to carry for 24 hours. So showing that this can be done in a non-invasive way, and you deploy the capsule in the esophagus. And here is what we all use. So the methodology is not new for you, but this publication should be new to you in the sense that this is how they showed that a wireless system that can successfully record esophageal acid exposure for 48 hours. So this changed both clinical practice as well as research. Now you could test drug therapy for 48 hours. And now if you place 2 capsules, one after another, you can do it for 96 hours. So again, a very unique way of how we can now do pathophysiological studies in patients with gastroesophageal reflux disease using this wireless system. And finally, we come to the classification and the disease definition in 2006. Again, almost 60 years after this disease had been first diagnosed, is an international working group which showed and defined that reflux is a condition which develops when there is reflux of gastric contents into the esophagus, which causes troublesome symptoms and or complications. So this is the contemporary definition of gastroesophageal reflux disease. And we all know that there may be esophageal component and extraesophageal components, and they did put this thing together with it. And this is when that definition was created in 2006. So consensus-based definition to simplify disease management and also to make studies more global and generalizable throughout the world, because this truly is a disease which impacts all corners of the world when you talk about gastroesophageal reflux disease in this situation. Then comes along a study finally comparing, the fundoplication that Nissen had described in the 1950s to the PPIs which were described in the 1980s. Which one is better? That was always a question. And Galmiche and colleagues put together this very beautiful European study, which was the 5-year follow-up, was published in JAMA, in which called the Lotus Randomized Controlled Trial, Laparoscopic Fundoplication versus PPI for chronic reflux disease. And what this showed was that both therapies were comparable. There was no significant difference between the two in treating the disease and maintaining remission at 5 years. And there was before this always this debate, is one better than the other? How should we do it? And the surgeons kept saying surgery was better. The gastroenterologists wanted to, of course, treat everyone with PPIs. But for the patient who was left in the middle, this was this landmark paper which gave us the information that we needed and how to successfully manage patients with gastroesophageal reflux disease. Then I leave you with this final study from the 2020s. And again, the reason I picked this up more so than for its impact is that what's the GERD that we are dealing with today? And that's refractory GERD. And that's the more contemporary GERD that we all have to deal with in 2020, because the acid problem or part of the acid problem may have been solved, but what remains is this prevalence study showing that 2 out of 5 patients in the US still have reflux symptoms. 1 in 3 in the US still have reflux within the past, week. And of those patients taking PPIs, 1 of 2 still have persistent symptoms. So despite GERD being diagnosed and described in the 1930s, 70 years on, I don't think we've solved much. It's still highly prevalent. 30% of the US population suffers from it. We have good treatment, but patients are not satisfied with treatment. And this large population-based survey suggested that 40% of the adult US population has reflux and 50% of acid users still have persistent symptoms. So the original GERD may have been solved, but we've created a new bad monster, which is refractory reflux disease. So this is what I'd like to conclude with, is if you look at it in chronological order for this. The first mention of Barrett's esophagus in the 1950s, in the 1930s for gastroesophageal reflux disease. The pathogenesis was described, you can see, almost 20 years after the initial disease was described. The diagnosis, for example, for cancer, very much late. So with advanced imaging, you can have the diagnosis with viral SpH monitoring described in 2003. Definition and guidelines have evolved over time, but the landmark guidelines are from the ACG in 1998 and from the Montreal Consensus in 2006. Classification system used the Prague classification system for Barrett's esophagus and the Los Angeles classification system for gastroesophageal reflux disease. And finally, you can see that the treatment of Barrett's esophagus with endoscopic resection and mucosal ablation described in the 1990s and early 2000, and for gastroesophageal reflux disease, the fundoplication procedure described in the 1950s, and then PPI therapies in the 1980s and 1990s, and then the randomized controlled trial. So, this is what I look as the landmark publications. Again, TSC was very strict, as always, with me that it can be only 10 or 11 publications. And so I had to, I'm sure, skip a number of publications which I have not shown here. And my apologies to all the experts in the field who I may have missed, probably, not purposely. So again, my apologies for that. And TSC, over to you as, the star moderator that I've best seen conducting any, panel discussion.
Pratik, fantastic. I think Prasad would agree with me. I like the way you proceeded. First mention, diagnosis, classification, and treatment. So fantastic. And I do agree with you. There are humpty number of papers. Everyone is very difficult to contain within 10 landmark publication. You have done a wonderful job. I enjoyed thoroughly. Now there are a lot of questions to both the panelists, both Dr. Pratik and Prasad. First question is from Dr. Jayanti. What is the percent of GERD developed Barrett's? And Barrett's is prevalent in India. Why it is so less in India? So both of you can take up.
Yes, a good question. And, Dr. Jayanti, obviously, hello, Dr. Jayanti. She's obviously, one of the stalwarts in GERD in India herself. So, and she was worked with, TSC, if you remember, on the GERD task force.
Yeah.
And actually, along with Shobna Bhatia, she showed that the GERD prevalence, the Barrett's prevalence is about 5 to 6% in the Indian population. So she's right, it is probably half that of the US. And even more importantly is that the dysplasia and the cancer is even lower. And, there may be several factors, both, epidemiological, both, phenotypical, genotypical, which may be working, in the favor of the Indian population. I always, for an easy answer, I always used to pick obesity and say it's because of obesity. But we heard before from, our experts, before that obesity is also highly prevalent in India. So unfortunately, I cannot use that excuse anymore. Maybe Prasad has a better idea of why it's low. But, I would say that GERD is probably equally common between the Indian population as well as the Western population. Part of the reason in defining GERD in India has been a clear-cut definition. The problem of different languages there. How do you describe GERD? Many of the patients in India refer to GERD as gastritis, or belching or burping or excessive gas. So it's very difficult to know the exact prevalence. And perhaps I think after Prasad, TSC, maybe you can answer that better along with Dr. Jayanti on some of these issues. Prasad, please.
Okay. Prasad, you will pass on the difficult question to you now. Why it is less in India?
I think, Pratik hit a lot of the highlights. I think Dr. Bhatia and Dr. Jayanti have really, in some ways, done the landmark studies in India showing that if you systematically look for Barrett's in patients with and without reflux, you're probably going to find it. Maybe slightly lower prevalence, but the other pitch I would make is, maybe another point I would make is probably, I don't know if the incidence and prevalence of adenocarcinoma of the esophagus is as well described in India as it is described in the West. though I think anecdotally we know that it is less common. Squamous cell cancer is the more common variety of esophageal cancer that I think most of you see. The other thing that I would probably also mention is the influence of genetics. There is emerging data to show that polymorphisms in the injury pathway, these could either be sex-based, these could either be race-based, do affect how the cells respond to injury and how they move from injury to metaplasia to cancer. And I know there are studies that have looked at the difference between Caucasians and African Americans, and there's been some interesting data from Amitabh Chak's group. So I suspect there are those differences which may be playing a role as well. The second thing might be diet as well. I think in India, the consumption of red meat is not as high as that in the West. And I think that may have a role to play as well. And then the third thing is other nutritional factors, like other nutritional or even infectious factors like Helicobacter pylori. We know that there is an inverse correlation between Barrett's and esophageal adenocarcinoma and Helicobacter pylori. So with the higher prevalence, the population in India might be somewhat protected against that as well. So I think these are probably more hypotheses, but we need to see more evidence.
So the thing is, red meat eating, number one. Number two, some genetic factors. Number three, H. pylori may be responsible.
Yes,
I was under the
TSC,
impression-
whenever
Yeah.
we will give you very long answers, that means we don't know what we are talking about. Okay, so that's the.
We usually start with a more difficult question. We have around 52 questions on GERD and Barrett's. We'll take up as much as time permits, and we want a brief answer to the pointed question. And you asked my views now. Initially we thought we are missing GERD and we are missing, as you said, Barrett's also. After the advent of NBA and after the advent of that paper that minimum you have to spend 5 to 7 minutes for upper GI endoscopy, I've been diligently doing the kind of endoscope like that, and my colleagues also. We do see GERD, but not as severe as what you see in Western population, number one. And we are very careful to look into the Barrett's. We don't see, hardly we see a few cases in a year. That has been the experience. And what is protecting, I think you can do a study, collaborative study on this. So there is a fertile idea available for you now. Now the second question is, what is the percentage of GERD turns into Barrett's?
So, I mean, it's hard.
This is from
So
Dr.
the question
Gokul.
is,
Dr. Jayanti again.
Yeah, so the prevalence in the US population is between 10 to 15%, depending on the type of population you evaluate. If you're closer to a population-based study in Rochester, it will be closer to 10%. If you do a study, in patients with risk factors such as, again, smoking, obesity, etc., and it will be closer to 15%. So that's what it is in the US. And as I mentioned, in India, it's probably about half of that in the GERD population. If you look at all comers in the population prevalence in any patient undergoing endoscopy in the US, it's about 1%.
Okay, a question from Nepal, Dr. Bidan Nidhi. Can PPA prevent Barrett's? What is the role of NSAID and statins in preventing or treatment of the Barrett's?
So, and I don't know, Prasad, should we alternate TSC how you want to do it? I just don't, I want to make sure we hear from Professor Iyer too.
To Prasad, how do you, can PPA prevent Barrett's? Dr. Bidan Nidhi from Nepal is asking the question.
Yeah, I think the best evidence, I don't think there is direct evidence of prevention. It is very hard to actually do this in humans, of course. But we do know for a fact that when we ablate Barrett's and we put people on PPIs, we actually cause the Barrett's to disappear in 80-90% of folks. And we also know that if there is reflux which is uncontrolled, then the Barrett's can come back. But in those where the reflux is well controlled, the rates of recurrence of Barrett's are low. So I think we have some indirect evidence. There is also some data from the United States to show that over the last few decades after the onset of PPIs in the 80s, the length of Barrett's that is being diagnosed might actually be reducing as well. So I think we have maybe some indirect evidence to suggest that there is a protective effect of PPIs on Barrett's, though Prateek has shown that once established, Barrett's doesn't go away. The length remains the same. Even if you stay on PPIs, you may get a few islands of squamous mucosa, but it really doesn't shorten as such. So I think that was question one. The second was smoking and statins, sorry?
NSAIDs and statins.
NSAID.
Yeah, so I think again there is a lot of circumstantial and epidemiological evidence to suggest that if you take aspirin or NSAIDs or statins, mostly non-randomized data, that the incidence of adenocarcinoma is reduced. So, however, there is limited data to suggest that you should be on aspirin if you have Barrett's to prevent cancer. In fact, the ASPECT trial that was published in Lancet, I think last year, didn't really show a beneficial effect of only aspirin. The combination of aspirin and a PPIs was what really led to a reduction in incidence. So hopefully I've answered the questions.
Yeah,
And
well said about
TSC talking about the prevalence, going back just briefly to the first thing is, what we are seeing is that the prevalence of Barrett's may be decreasing, at least in our center. So one of the things we looked at, which is going to come out in publication in the next couple of months, is that over the last 20 years, the prevalence at our unit has significantly decreased. And the only two factors which had a negative association with the decrease was increased use of PPIs and a reduction in smoking. So we feel that these may be, again, two indirect factors to the question from our Nepal expert, is that perhaps, reduction in smoking and use of PPIs, those are maybe two factors, indirect evidence, which can prevent Barrett's.
Very good. So well said about NSAID. Now, aspirin also can promote a reflux, no? If you were advising aspirin.
Causes dyspepsia, TSC, not reflux. So it can cause
reflux. Dyspepsia only. Okay, question to you, Dr. Prateek. The Seattle Protocol. A question from the surgeon from Raipur. The Seattle Protocol, how commonly it is followed in US and the rest of the world? What is the alternative? Taking so many biopsies, you really practice this?
So it's followed by 50% of the people all around the world. This is not just for the US, but also for Europe. And the alternative to that is doing a good Barrett's inspection time and washing clearly, looking for any mucosal abnormalities, getting good at use of chromoendoscopy, either virtual or spray, and then taking target biopsies.
Okay, I think continuous of the same question is, if you take multiple biopsies like that, will it affect when you want to plan for EMR or ESD in Barrett's esophagus?
That's only if you have a lesion, right? If it is flat Barrett's, then, most of the time that's going to come back as non-dysplastic and you won't be resecting it. But I think the question pertains to if you find a lesion in the esophagus, and I think this is true for any lesion in the entire luminal GI tract. If you see a lesion that you want to eventually remove, try to take very few biopsies of that lesion because it will make subsequent EMR and ESD difficult. Question
from Gupta. The thing is, Barrett neoplasia is supposedly common between 12 o'clock position and 3 o'clock position or in the right hemisphere. Do you recommend spending more time in interrogating or inspecting this area, or why it is common like that? The
So the
Prasad.
reason is common is,
Yeah.
sorry,
You
go
can-
ahead, Prasad. Sorry.
No, that's fine, Prateek. So there are some anatomical reasons. Again, these are all hypotheses. I don't think we really know for a fact. There are studies which have shown that I think what the questioner is answering is there have been studies which have shown if you look at the esophagus like a clock, then the right half of the esophagus is perhaps where you see more lesions. I even though several studies have shown that, I still believe that lesions can occur anywhere. You need to be very careful in examining all areas, but I think it's reasonable to look at those areas more carefully, but not at the cost of not looking at other areas. Physiologically, there may be the hypothesis I have read about is that there may be more pooling of acid in those areas. It also depends on anatomic abnormalities as well. So my answer to that would be look everywhere and
Look
not just
everywhere,
at
but
that
more
area.
cautiously in the right hemisphere.
That's reasonable, I think.
Okay. A question, very interesting question to Dr. Prateek. A patient who has got GRD, what posture you advise them in while sleeping? Right lateral, left lateral, supine?
Yeah, so I mean, there were initial studies on 24-hour pH monitoring, which showed that more acid reflux occurs in the right lateral position, and so there was some suggestion that perhaps that's how we need to tell our patients to lay down and do it. But it has there's a good paper by the former Lauren Gerson looking at some of these conservative measures. And the two measures which always stick out with the best evidence is elevation of the head of the bed to 30 degrees or higher. And the second one is avoiding snacks or a meal between your dinner and going to bedtime should be at least about 3 hours. So those are the two measures in the best evidence which have shown that. All the other things are good suggestions that we can always take, make us feel better, make the patient at least mentally feel better, but there is no scientific rationale for it.
Prateek, a very interesting observation in India is you are telling about snacks between the dinner and the bedtime, but we have dinner just before the bedtime.
Yeah. So, and again, I think that's a big contributor to it. And, that's why, if you remember, our parents still take a walk after eating dinner, right? And everybody does that. That was part of the reason, there is no scientific evidence for it because a study wasn't done. But the reason to take that post-dinner walk is actually exactly that, which is you move all your gastric contents down so that when you go to bed, you're not refluxing.
You are not reflexing it. Fantastic. My colleague Satya, organizing secretary, wants to ask some question.
Can he ask? Is the organizing secretary allowed to ask questions?
Yeah, sir. You want to ask something?
Yeah, Satya, please go ahead.
Yeah, sir.
You were about to say something.
I think TSE has put him on a spot.
So as a budding endoscopist, so in endoscoping in reflex patients, so which endoscope would be better, like ordinary white light endoscope with high definition alone, or with NBI, or you still a near focus or magnification endoscope? What specification of the endoscope is required in endoscoping GRD patients?
Yeah, I think the aim should be to use the best endoscope that you have. High definition monitors, high resolution white light. If possible, NBI can help. Make sure that you do basic things like cleaning the GE junction, spending some time inflating, deflating. The role for, I think, NBI and or magnification endoscopy would come more in a patient where you have known Barrett's or where you see a visible lesion. where you perhaps want to interrogate the mucosal and vascular pattern a bit better. But in a routine endoscopic evaluation, I think the best endoscope that you have, and I think all endoscopes right now from every company has some kind of electronic chromoendoscopy. You know, whether it be Olympus or Fujinon or Pentax, they all have their version of electronic chromoendoscopy. The issue in my mind is to slow down, clean, and take a good look, and spend some time. I think those are perhaps equally, if not more important than the kind of endoscope you use on a general basis.
So what?
Pratik, I don't know if you have other thoughts.
Yes, sir. So what is the role of your the cytosponge, sir? Cytosponge you introduced to Dr. Prasad, sir. Prasad Ayers.
Yeah, I think what you're referring to for people in the audience who may not have heard of this is this device called the cytosponge, which actually was first described by Dr. Fitzgerald from the United Kingdom, which is a small capsule with a piece of compressed foam, which is attached to a string, and you swallow the capsule, the shell dissolves, it releases the sponge, and then when you pull it out, you get cells from which you can actually do biomarker analysis to look for the presence or absence of markers to predict the presence of Barrett's. I think that is a promising technique. Several studies have been published in that area. There was a paper in the Lancet this year with a large randomized controlled study. So I think it is perhaps most suitable for situations where the prevalence of Barrett's is relatively high. Perhaps first in the Western populations. I think its goal, its role, and its accuracy in a country like India is yet to be determined, because I think we are even trying to figure out what is the prevalence of Barrett's. How often does Barrett's actually lead to esophageal adenocarcinoma? So I think all those issues have to be first defined a bit better in the East before we can start moving the cytosponge. Now, one role where the cytosponge may have in the East is for the diagnosis of squamous dysplasia and squamous cancer. And there's been some work where you can use the same device, but combine this with a different set of markers. So particularly in countries like China or Iran, for that matter, I think it may have more of an immediate role there rather than for the diagnosis of Barrett's.
Okay.
The very controversial relationship between Barrett's esophagus and H. pylori. What is the present consensus and what is the concept? Pratik, question from my colleague Farooq from Bangladesh. Should we treat H. pylori?
So studies have shown a negative association or a relationship, but not consistently. It's been different in different populations. And part of the thing is that probably it's not related to H. pylori itself, but it's probably related to the type of gastritis, which is caused by H. pylori. And so that may have a negative, prevalence relationship with Barrett's esophagus, because as you know, if you have antral predominant gastritis, you have increased acid production. Whereas if you have pan-gastritis, you have decreased acid production. So in countries where there is decreased acid production because of pan-gastritis, eradication of H. pylori may lead to more acid production or back to baseline. And those patients, if they were predisposed to GERD to begin with, they may start having some symptoms. So to me, I mean, that's the effect of it. I mean, I don't think that should be a major concern for anybody. One of the things that we always hear is a patient comes in with GERD and everyone's checking for H. pylori, and I don't see any reason why you need to do it. Many of the physicians or endoscopists in the US also do it, is that a patient comes in for endoscopy for GERD and they'll take biopsies from the antrum. And for the longest time, I couldn't figure out why they were doing it. And then I found out is because if you take a biopsy, you get paid more rather than if you just did an endoscopy without a biopsy, right? So you have to define clearly why you are checking for H. pylori. If a patient has dyspepsia, if a patient has ulcer disease, patient has family history of gastric cancer, I think those are all reasonable indications to check for H. pylori. So it all depends on what you're doing with that information.
Okay, now we have come to the last one or two questions. After that, we have to wind up now. We have our bariatric surgeon, bariatric endotherapist, Dr. Galvia, also with us. Dr. Galvia, Professor Neto. Hi. Hi. He want to ask some GRD specialist some question related to obesity. He was waiting for us. Okay. If not, hello? Hello? Okay, the basic question somebody is asking, there is a small isolated islands of columnar epithelium above Z line. What is your opinion?
Just
Above the
don't
Z
bother with
line,
it unless you see
you don't
something
bother.
abnormal within it.
You don't need to take biopsy or anything?
No, I mean, if it's just islands and it looks flat and there's nothing suspicious in there, I mean, those islands are benign.
So how do you report it?
Just said you
report it
saw
as
islands.
a few islands and
Yeah.
insignificant.
Mhm.
Unless you see some elevation or something like that.
Exactly.
Or
Exactly. Yeah.
otherwise, flat lesion, you can, you don't have to
Right.
worry about.
Because they won't meet the definition of Barrett's esophagus anyway.
Mm-hmm. You
Yeah.
don't need to do that.
Right. Prasad,
Okay.
you do anything differently with those?
No,
Prasad
I think
likes to
that,
biopsy, I know.
yeah, yeah. I think the point that Pratik is trying to make is that for a diagnosis of Barrett's, you need at least a centimeter of columnar mucosa, which is extending up from the GE junction, and that islands alone do not constitute a diagnosis of Barrett's. So,
Right, but what would you do, Prasad, if you saw two small islands above the Z line?
above the Z line,
Yeah, small
if-
islands, nothing else.
yeah, I probably would look carefully with white light and narrowband imaging. If it doesn't bother, if it looks regular and flat, I would probably not biopsy it.
Okay.
Okay,
If I
last
see tongues,
question.
I will. If
Yeah,
I
you
see
will leave
tongues
it like
coming up
that.
from
If it is
the
flat,
junction,
no nodularity. Okay, before our ordinance secretary conveys this vote of thanks, I just want to ask Pratik, how did you enjoy? How much you found it difficult for this topic?
Oh, this was tough. TSC. I mean, as I said, I had to do I could have written a paper and a meta-analysis in the meantime because you made me do a literature search and I had to go back. I first sort of like just sat down with a pen and paper and tried to figure out what were the areas I wanted to cover. And then I went through the major papers in that area. So some of these papers I had not read. So, for example, about the original Nissan thing, I read the abstract for that and stuff. So as I said earlier, it was a learning experience for me. If you hadn't given me this opportunity, TSC, I probably would not have read some of these very important papers. So I feel better educated now.
So hope you are not cursing me. Still, I am your friend.
No. You're still my friend. I don't like the hat, but besides that, you're my friend.
Okay. Okay, it's a fantastic. I really enjoyed it, and both the speakers have done a wonderful job. Professor Nate also said it was a tough job to read, and after reading, I got 50 publication. How to bring it down to 10 publication was a Himalayan task. So I had to really do the hard work. He said, I think disturbing on the weekend to early morning, waking both of you and coming forward to contribute for the benefit of every one of us. A great thing happened. I love the way you discussed the thing, and I love the way Dr. Prasad interacted. Thank you very much for both the panelists. Now, mic is over to Dr. And before that, you asked Jayaraj.
Nice, he's on.
Jayaraj.
Jairaj is muted.
Unmute, Jairaj.
It's fine, sir. Dr. Satyamurthy can give the word of thanks. Anyway, sir, nice to nice to have you all here. Absolutely a constellation of stars, I should say. Proud to be associated with this wonderful 10 most impactful landmark publications in gastroenterology webinar. I must thank first, of course, Dr. Chandrasekhar, the organizing chairman and the anchor, and also the luminaries, the speakers, and the panelists for being with us. From on behalf of Microlabs, big thanks to all of you, sirs. Thank you. Dr. Satyamurthy.
On behalf of the organizing committee, it gives me an immense pleasure to conclude this wonderful session with a vote of thanks officially. So at the outset, I would like to thank the organizing chairman, Dr. Chandrasekhar sir, who is the brainchild of this innovative webinar series, for his untiring efforts in taking this webinar forwards to an international level. And kudos to him for his excellent selection of the topics and choosing the most eminent faculties. I would like to thank the American College of Gastroenterology and the American Society for Gastrointestinal Endoscopy for endorsing this unique webinar series, which had attracted more participants from various parts of the world. I would like to thank both the international Harvard speakers who are the heroes of today's session, the most adorable and passionate teacher, Professor Manuel Galvo Neto, and the ever-charming Professor Dr. Pratik Sharma for consenting to take part in this program. Your participation has added immense value and has generated an overwhelming response from across the globe. I thank you for spending your valuable time in preparing these difficult lectures and for the excellent presentation. We all enjoy listening to your lectures, and both of you were at your best in your own way. I would like to extend my gratitude to the senior international panelists, Dr. Prasad Iyer, and the learned national panelists, Dr. Mohit Bhandari and Dr. Rakesh Kalapala, for providing your valuable expert comments. I would like to thank the MedIndia team, especially my senior colleagues, Dr. Gokul, Prasad sir, Dr. Raj Yogesh, and the admin team and the computer department, Sasikala, Sasidran, Shiva, Selvi, for their excellent coordination and technical support. I would like to extend my special thanks to our academic partners, Microlabs, Mr. Jairaj sir and his team, Mr. Swak sir, Pranita, Karthik, Padmanabhan sir, and Srinivasan for their continuing support and putting their best effort in organizing and coordinating the webinar, and without them, this event would not be possible. So, and finally, I would like to thank the delegates and the participants for spending your valuable time in attending the webinar, and without your participation and support, this wouldn't be a great success. And with this, I conclude this session, and I am eagerly awaiting to catch you all in the upcoming 7th webinar session, which is on 23rd Jan 2021.